Good afternoon, everyone. Welcome to the first webinar for the NARI OPWA webinar series for 2022. Sorry, I just had to check for a second that I know what is the actual year. My name is Alex Bahar-Fuchs, and I'm a Principal Research Fellow in the Academic Unit for Psychiatry of Old Age. Thank you for those of you who are able to join us today. I am very, very excited to be able to introduce today's speaker, the first speaker for this year, who happens to also be my PhD student, Julieta Sabates, who actually is joining us to give this talk from the other side of the world, where she is currently in Buenos Aires, Argentina, her original home country. And Julieta is giving this talk when it's just after 10 p.m. her time. So thank you, Julieta, for staying up to give a talk this late by Australian standards. I know you've just had lunch in Buenos Aires, knowing the Argentinian culture. Julieta, as I said, who is a PhD student in our group, is going to talk to us today about neuropsychiatric symptoms in people with younger onset dementia, and describe a novel app that she's developed as part of her PhD targeting these symptoms. So Julieta is a PhD student and a research assistant within the Cognitive Interventions, Technologies and Evaluations Research Group, which is the group that I co-lead with Amit Lampi in the Academic Unit for Psychiatry of Old Age. Her research focuses on cognitive interventions for neuropsychiatric symptoms for people with younger onset dementia. Before starting her PhD, Julieta completed training as a psychologist at the University of Buenos Aires and specialized in schizophrenia spectrum disorders. Since then, she's moved to Australia and she's worked in our group as a research assistant for a couple of years before, thankfully for us, choosing to stay and do a PhD with us as well. And she's also worked as a research assistant, obviously, for NARI for quite a while, quite some time as well. So that's it, really. Over to you, Julieta. I hope that you enjoy Julieta's talk, and hopefully it will generate some questions as well.
Okay, thank you, Alex, for the introduction, and hi, everyone. I'll share my screen first. Can you see my screen?
Yeah.
Okay, thank you. So, hi, everyone. As Alex said, I'm Julieta Sabates, and I'm a PhD student. So I'm going to talk about ReMinding, which is an app that I designed and developed as part of my PhD. So thank you for being here and for expressing your interest in hearing me. So the main aim of my PhD was to design, develop, and evaluate a novel mobile application-based intervention that targets neuropsychiatric symptoms of people living with younger onset dementia. And I'm going to explain what this means now. So currently in Australia, there are approximately 487,500 people living with dementia. And this number is expected to increase to almost 1.1 million by 2058. It is also the second leading cause of death in the country and the leading cause of death for women. Up to 1 in 10 cases of dementia have an onset of the symptoms before the age of 65, and these cases receive the name of younger onset dementia. There are approximately 29,000 people living with younger onset dementia, or YOD, as we also call it, in Australia, and this number is also expected to increase to 41,250 people by 2058. The most common causes of younger onset dementia are Alzheimer's disease, or AD, vascular dementia, and alcohol-related dementia. We believe that dementia is likely to be more disabling for younger people because they are people that are likely to still be working or to have to care for younger children or aging parents. For this reason, also informal caregivers of people with younger onset dementia, so the people that care for them, usually report worse quality of life than carers of older people with dementia. So despite having its own needs and its own characteristics, young onset dementia is still a relatively unexplored population. And even in 2022, there aren't enough age-appropriate treatment approaches that address these specific needs. So it is clear that there is a need for further research in the field, and this is the main reason I decided to do my PhD focusing on an intervention for people with younger onset dementia. So as you may know, the main symptoms of dementia are a severe decline in cognition and in functional abilities, and these symptoms tend to get worse as the disease that causes the dementia progresses. These symptoms are usually accompanied by what we call neuropsychiatric symptoms that are behavioral and psychological disturbances that are highly frequent in people with dementia. They used to be called behavioral and psychological symptoms of dementia, or BPSD, but nowadays the preferred term is neuropsychiatric symptoms. So they include several symptoms and behaviors such as anxiety, depression, psychotic symptoms, wandering, sleeping or eating disturbances, apathy, disinhibition, among many other symptoms. So as you can see, there are very different symptoms. It's a very broad term. In terms of how common they are in people with dementia, although the prevalence varies a little bit across studies, it is known that at least 90% of the people with dementia will experience a neuropsychiatric symptom over the course of the disease that causes their dementia. And this is also true for people with younger onset dementia specifically. In fact, there are some studies that show that the prevalence of neuropsychiatric symptoms can be higher in people with younger onset dementia than in people with older onset dementia, and that in younger people, they can produce greater caregiver distress. They have been shown to be persistent and to be linked with worse disease progression, as well as increased distress and burden in the caregiver, which has also been associated with higher rates of institutionalization of the person with dementia and with earlier admission to a nursing home, which, as you can imagine, is particularly problematic when we're talking about younger people with dementia. So for this reason, clinicians try to treat these symptoms, and there are two main forms of treatment: pharmacological interventions and non-pharmacological interventions. In relation to pharmacological interventions, some drugs that have been used or that are sometimes used to treat these symptoms are cognition-oriented drugs, like the ones that are used, for example, in people with Alzheimer's disease to try to depress the pace of the cognitive decline. But although these have been shown to produce some small effects, they also have some side effects. So they are not ideal for the treatment of neuropsychiatric symptoms. Another type of medication that is sometimes used, especially for the treatment of psychotic symptoms like delusions or hallucinations, are antipsychotics. But in this case, there are also some side effects. So it has actually been associated with higher mortality rates and with more cognitive impairment, which of course is far from ideal in any person, particularly in people with dementia. So another type of medication is an antidepressant. And although there is some evidence on their effectiveness, mainly in relation to mood-related symptoms, they have also been associated with a decrease in cognition. So, of course, their use is restricted to those cases in which the benefits clearly outweigh the risks. For this reason, the preferred form of treatment are non-pharmacological interventions, and these are the first-line treatment if we follow the recommendations of the Australian and international clinical guidelines for the treatment of neuropsychiatric symptoms of people living with dementia. So non-pharmacological interventions, just like with neuropsychiatric symptoms, is also a very broad term, and it can include anything from physical activity to psychotherapy. So it is really hard to evaluate the effectiveness of these interventions because it is not one intervention, but rather several types of interventions. So as an example, I can tell you that multisensory stimulation or physical activity, for example, showed some evidence of an effect towards improving neuropsychiatric symptoms, whereas light therapy or aromatherapy, for example, didn't show these effects. So when I was having to decide what type of intervention I wanted to try to evaluate with the participants of my studies, I decided to read about the etiology of the neuropsychiatric symptoms because I thought that the treatment had to be somehow linked with the cause of the symptoms. So I read a lot about the different theories that are behind the cause of the symptoms, and some of them are, for example, that they are a consequence of unmet needs. So the person with dementia has unmet needs, and if we address these needs, we can maybe decrease the expression of neuropsychiatric symptoms. Another hypothesis is that they appear because the person with dementia usually has a reduction in the stress threshold, and that this leads to an overreaction to stimuli, and this overreaction would be a neuropsychiatric symptom. Another hypothesis is that they are a direct consequence of changes in the brain, but none of these hypotheses can really explain the wide variety of symptoms that we can see in people with dementia. So my hypothesis is that both impairment in cognitive processes such as in attention or memory that we know are frequent amongst people with dementia, as well as metacognitive processes such as attitudes or beliefs are likely to play a role together in the expression of neuropsychiatric symptoms. And for this reason, I decided to design an intervention that would target both kinds of processes simultaneously. So drawing from my experience as a research assistant in the field of cognitive training, where I did some research that showed that cognitive training could have a positive effect on people with dementia, and also on my experience as mainly as a student of psychology, where I learned a lot about cognitive behavioral therapy, and I also read that it is feasible in people with dementia, although there is a common thought that people with dementia are too impaired to engage in any sort of psychotherapy. I decided to combine these two types of interventions, of course, making some adaptations because of the population that I was targeting. So for those of you that don't know these interventions, cognitive training is a cognition-oriented treatment in which the person engages in the repeated practice of standardized tasks that target one or more cognitive abilities. And there is the idea that by practicing, you can improve or maintain the trained skill, so the underlying skill, and that these can transfer to everyday life activities so that you can maybe improve your everyday functioning by improving the underlying skills of the task that you are practicing. This can be done either in pen and paper or in a computerized way, or it can be an individual treatment or as a group format. So in my case, I am including elements of this intervention in a mobile application. And then cognitive behavioral therapy is a form of psychological treatment that focuses on trying to change thinking or behavioral patterns that are unhelpful, and trying to help the person maybe adapt some ways of thinking or some ways of behaving that are more effective or that are more adaptive for the challenging situation. And this can be done with the help of a therapist, or in some cases can be done with the help of a book or with the help of a mobile app, as in the case of my study. So I combined elements from both types of interventions, and I designed ReMinding, which is a treatment that I decided to deliver via a mobile application, maybe because, mainly because this is a cost-effective way of providing treatment to people that would otherwise maybe not be able to afford a regular session with a psychologist, for example, or that live far away from a clinic, and so maybe they would not even reach out to someone for help. So of course, this is not aimed at replacing the psychologist or replacing the doctor or replacing anyone. This is just a further source of support. And although I started my PhD in 2019 when we knew nothing about the pandemic that was about to come, in 2020, I confirmed that it was a good idea to try to design something that people can access through the comfort of their homes. Because for a couple of years, that was the only way, or at least the main way, that they could access any form of treatment. So I designed this intervention following the Clarify, Design, and Evaluate, or CDE framework for designing and developing mobile health applications. And I will take you through each of these phases. So the main aim of the Clarify phase is to define the need of the application and what the focus of the app will be. And this is generally achieved by a combination of qualitative and quantitative research methods. So in my case, I conducted 3 background studies. The first of which was a systematic review that looked at the associations between neuropsychiatric symptoms and cognitive skills in people living with dementia. The second study was a qualitative study that looked at the perspectives of psychologists that deliver psychotherapy to people living with dementia on, psychotherapy for people with dementia. And the third study was another qualitative study, in this case with people living with younger onset dementia and their carers, where I asked them questions related to the use of mobile apps, mobile phones, and so on. So the first study, as I said, was a systematic review looking at the links between neuropsychiatric symptoms and cognition in people with dementia. So I was interested in learning about the links between overall cognition and overall neuropsychiatric symptoms, but also between specific neuropsychiatric symptoms and specific cognitive abilities. So for example, I wanted to know if impairment in attention was associated in any way with increased agitation, for example. So I conducted a systematic search and I found 87 eligible studies. I conducted the meta-analysis in R, and I found some significant associations. I have presented some here. The manuscript is in progress right now, so hopefully it will be submitted and hopefully published soon, and you will be able to read about the results. But some preliminary results that I can show you are that agitation was shown to be associated with global cognition, as well as delusions and hallucinations. So psychotic symptoms were also associated with impairments in global cognition. And apathy, which was also associated with impairments in global cognition, was also shown to be associated with impairments in several other cognitive skills. So I took this information when I was designing the app, and I decided to add more cognitive tasks, for example, in the sessions that were targeting apathy. So in the sessions that target apathy, I added more memory tasks, more semantic knowledge tasks, and more visual-spatial skills tasks. The second study that I conducted was a qualitative study with psychologists that delivered or had delivered psychotherapy to people with dementia. And it was conducted over Zoom. I did 9 semi-structured interviews, and they were psychologists from all around Australia. They all indicated that cognitive behavioral therapy, or CBT, was their preferred framework for working with people with dementia. And when I asked them about what techniques they found useful or helpful when working with people with dementia, they indicated that they did a lot of psych education, that they also found mindfulness very useful, and that they found that it was really important to try to refocus the patient's attention onto activities that they can still do and that they enjoy, and on the strengths that they still have, as opposed to the disability or the things that they can no longer do. Although none of them currently recommend an app to their patients or include an app in their sessions, they did say that they were willing to include ReMinding in their practice, or at least to recommend it, of course, if it was shown to be feasible, effective in reducing neuropsychiatric symptoms, and cause no harm to the participants of my study. So I took this information as well when I was designing the app. So this was the second study that informed the design of the application. The third study was a qualitative study with people living with younger onset dementia and their caregivers, and it was about the use of smartphones and mobile apps. So this was going to be conducted in the Royal Melbourne Hospital in person, and they were going to complete a form when they attended their usual appointments. But because of the pandemic, this had to be moved to a completely remote study. So they had to complete a questionnaire, an online questionnaire, and I think that these impaired my ability to recruit as many participants as I was hoping to. So I was able to receive responses from 5 people with younger onset dementia and 7 caregivers, which is of course better than nothing. And all of them indicated that they had a smartphone, and all of them had an iOS operated phone, which is an iPhone, as opposed to, for example, a phone that is operated by Android. So I based my decision of what operating system to build the app on first on this study. And so the developer of the app focused on iOS first, and only after that, they focused on Android. 4 out of 5 patients indicated that the time that they used the phones had increased since the onset of their symptoms. And this further made me think that I had to do something that was valuable for them, so that made the time that they use their phones more valuable. None of them had ever used a mobile health app. So one of them said that they had been recommended one once by a psychologist, but that they hadn't used it. And they weren't familiar with any cognitive behavioral therapy or cognitive training apps. So I also learned that I was going to have to, of course, give them a lot of information about what cognitive training is, what cognitive behavioral therapy is, and why it is important to try to engage with these kinds of apps. And last, they also gave me some insight on what they thought the app should have, so how an app designed for them should be. They said that they preferred bright colors as opposed to pastel colors, that they wanted the app to include images and sounds. And they also said that they wanted some other things that it was not possible to do with the developers that I was able to hire. But the app that I have today is just a first draft of what I think will be a better app in the future. And then I moved on to the design phase, which meant a very long iterative process of design and development between myself, my PhD supervisors, and my PhD advisors, including an expert on cognitive behavioral therapy and a dyad of a person living with younger onset dementia and their caregiver. So I designed a session, I sent all of them each of the sessions, and they provided me with feedback. And then, of course, I made the required changes. And yeah, it was a very long but interesting process. And I learned a lot while I was doing that. So I really enjoyed it. So ReMinding currently targets several cognitive domains, which according to our classification are attention, executive function, memory, semantic knowledge, social cognition, speed, visuospatial skills, and working memory. And 4 neuropsychiatric symptoms that were deemed of particular importance during my discussion with clinicians. And these are anxiety, depression, apathy, and disinhibition. So the app consists on 8 sessions, and it is aimed at being used twice a week. So there are 2 sessions for anxiety, 2 sessions for depression, 2 sessions for apathy, and 2 sessions for disinhibition. So each of these sessions contains cognitive tasks. So for example, in the anxiety sessions, there are attention tasks that are about the symptom anxiety. There are executive function tasks that are about the symptom anxiety. I will show you an example in my next slide. So as I said, I combined elements from cognitive training and cognitive behavioral therapy. And an example of this is that the difficulty of the tasks is adaptive, which in the case of my app means that the difficulty increases as the person or the user of the app performs correctly. So for example, a task can have 3 levels, and after 3 correct responses, the app moves to the next level. But then after 3 mistakes in a row, that particular task is terminated. And this is to avoid a situation where the user or the participant of my study in this case feels frustrated because they cannot respond correctly. So whenever they respond correctly, they see a green tick like this one here. And when they make a mistake, they see a small red cross, and then they are shown the correct answer, and they are prompted to respond again. And this is to aid the learning effect. The app also includes feedback, of course, as I just said, and it includes assessment of the current mood of the person or the current state, so how they are feeling at the moment. And this is included before and after each of the sessions. So as you can see here, they can select all the words that apply to how they are currently feeling, or they can select none if the way they are feeling is not in the screen, or they can select other and type a word in. Another thing that is included is Psych Education. There is a lot of these, a lot of information about each of the symptoms, a lot of information about what the signs are, how that symptom feels, how they can recognize when they are feeling that way, how they can recognize when another person is feeling that way, what things can be done to feel better whenever they are experiencing one of those symptoms. And we provide them with a lot of management strategies, which are, of course, all evidence-based, although there is always a disclaimer that says that they shouldn't engage in any of these activities without really consulting with a professional before doing that. So this is an example. We are telling them about the importance of exercise for the management of anxiety and depression, but in the next screen, we tell them that, of course, they need to speak to a GP because exercises, of course, it has to be tailored to their own capacities and needs. Another thing that is included is, for example, here you can see a social cognition task where the person needs to identify who is feeling sad. And this is in the context of a depression section, so a depression session. So the person is taught first that sadness could be a sign of depression. Of course, it is not always present in a depression. And of course, also the other way around is also true. But they are taught about how sadness could be potentially a sign of depression. And they're shown the facial expression of sadness. And then they are asked to try to identify which of the people that they are shown are feeling, which of them are feeling sad. So in this case, they have to select one of the pictures between two images, but in the next level, they have to select between 3 images. The same here. So here they have to complete a jigsaw puzzle with one of the pictures from the previous task. And in this case, it has 9 pieces. So this is level 2 of the puzzle. There is one puzzle that is easier and it has only 4 pieces. And if they respond correctly 3 times, they move to this task. And this task is aimed at improving visuospatial skills. Then there is another task where they see a list of words and one word is lit up and then another word is lit up and they have to remember the sequence and try to repeat it. And then we have the same task but backwards. So they have to repeat the sequence but backwards. Then here we have an example of a task where they have to select thumbs up if the statement corresponds to helpful thinking or thumbs down if it corresponds to unhelpful thinking. And this derives from a previous section where they learn a lot about the relation between emotions, thoughts, and behaviors, and about helpful and unhelpful thinking. So here you can see that we added some CBT-like components. Another thing that we have in the app are some mindfulness exercises, as well as relaxation exercises and distraction techniques. And so each of the sessions ends with an exercise like this. So if they click on this icon, they can listen to, in this case, the mindfulness meditation. These are just some screens, but of course, feel welcome to download the app. It's free, and to try to see the rest of it. And the last phase of the CDE framework and of my PhD is the pilot trial, which is my study 4. And it is a pilot trial because the main aim of the study is to evaluate the feasibility of the intervention. And this trial will then give place, hopefully, to a bigger clinical trial where I will try to investigate the actual effects on neuropsychiatric symptoms. Although we are already trying to look at a little bit at this in this trial, and also to see whether it can have any effects on cognitive outcomes as well. So it's going to be a randomized control trial with a waitlist control, which means that participants will be allocated either to the intervention group, and they will use the app for 4 weeks, twice a week, or to a waitlist control, where they will be asked not to download the app for those 4 weeks, but then after the study finishes, they will be able to download it at no cost. We are currently recording. We only just started because we only just heard from the developers that the app is available in App Store and in Google Play. And so please feel free to email me with questions if you have any interest in the study, or if you know someone that might be interested in participating. Here is a flyer of it. So we are looking for people with younger onset dementia, and this means that they must have a diagnosis of dementia, and they must have an onset of the symptoms before the age of 65. They don't need to be under 65 today. They just need to have had an onset of the symptoms before the age of 65. It is a completely remote study, which means there is no face-to-face interaction at all. And this has its pros and cons. On the one hand, we can recruit people from any parts of Australia, which is really good. But on the other hand, we cannot provide people with a mobile device, which is really unfortunate, because not everyone has access to a smartphone or a tablet. And the person also needs to have a computer, and that computer needs to have a camera. And this is because before and after the intervention, we will have to do a cognitive assessment. So a brief screening assessment at the beginning of the trial, which will also serve as a baseline assessment, and then the post-intervention cognitive assessment. And for these, they will need to draw something and show it to me via camera, and which means they need to have a computer with internet connection as well. So we know that this will, of course, make it a little bit harder to recruit 48 participants, which is our aim. But which is why I'm asking all of you, if you know someone that might be interested in participating, please feel free to let them know or let me know, and I can contact them. And they must have a support person, which means there needs to be someone that is next to them during the cognitive assessments, not necessarily during the time that they are using the app, but they have to be there during the cognitive assessments. During the screening session, we will try to identify those people that are actually eligible, because we are only able to include people that have mild to moderate dementia and that are able to engage with a mobile app, because we know that not everyone, particularly not everyone with dementia, will be able to engage with a mobile app. And we don't want a situation where the person gets frustrated or distressed because they cannot use the app. So these are some of the references. And I want to thank my supervisors, especially Alex, who's my primary supervisor, my PhD advisors as well, who helped me a lot, and the funding bodies of my PhD, which are Melbourne University and the TCRC, who very kindly gave us a grant in order for us to complete this study. So thank you, and I'll stop sharing my screen.
Thank you, Juli. That was really wonderful. Great to see the last 2.5 years of work summarized so nicely in this presentation. We have plenty of time, so I'm happy for any of you now to address any questions to Julieta. So I see we've got a question from Ruth about participant burden and who you might need to exclude from your fourth study on the basis of issues related to participant burden.
Yes, thank you for your question, Ruth. Yes, well, this is something that, of course, we expect. It's possible that it is likely to happen, and we do have a protocol in place for these. So if a participant becomes distressed or they tell us that they cannot continue with the intervention, of course, we will first of all reassure them that there will be no consequences if they decide to abandon the study or because they need to drop out. First, that's the main thing. We will make sure that the participants understand this from the beginning of the study, not only the participant, but also the support person. And then we do have a protocol in place where they will be able to speak either to me or to Alex or my other supervisors as clinicians. I'm not currently a clinician, but my other supervisors are. And they will be able to assist the person if they become distressed. Of course, depending on the level of distress that they are experiencing, we have different steps in place. But as I said, yes, we will exclude people that are too impaired to participate in the study, and we will cite this with the MOCA test that we will use in the screening assessment via Zoom.
And I suppose, Juli, it's worth maybe mentioning that being a kind of a pilot feasibility study, one of the goals of the study is also to better understand the extent to which this intervention is acceptable and feasible with participants. So it will be a very important contribution, I think, of this study, is to understand to what extent participants are likely to find this intervention acceptable or not.
Yes, absolutely. Thanks, Alex, for that. Yes, of course. It's an intervention that combines and that includes new things for people with dementia. As I said, there haven't been too many studies about cognitive behavioral therapy for people with dementia, or even for cognitive training studies for people with dementia, and especially using a mobile app. This is something that is completely new, the combination of these interventions and using a mobile app for them. So we have a lot to learn. And I think that, like Alex said, the main aim of the study is to see, is it feasible? Is it possible? What things need to be changed or removed or potentially added? And that is why, of course, there is an feasibility and acceptability questionnaire at the end of the trial that participants and their support people will complete. And this will give us a lot of information about what things they think could potentially make the intervention better. This is why I said the app is also a first draft of a good app that I plan to develop in the future.
While we wait for others to potentially generate any questions, I see that there's a follow-up comment about the possibility of excluding First Nations, poor people, or people from a culturally diverse background. Do you want to make any comment about that, Julie? Well,
yes, I do worry about that as well. So thank you for that comment. Yes, I realize, of course, a mobile app is not something that that is accessible for everyone. As I said, we would have loved to be able to provide people with a mobile device for everyone, an internet connection, and we would have loved for this to be an in-person study. It was not our choice, our first choice. We would have done things differently if we weren't in a pandemic. But yes, and in this case, the app is only going to be tested in people that live in Australia. And because the app is in English only at this stage, at least, we understand that it can maybe exclude people whose first language is not English. But yes, it is, of course, part of the project and part of my hope to be able to include other populations in the future and to make more versions of the app in all languages. And the app is free, and so the aim is that everyone can download it at no cost. But yes, I do understand that not everyone has access to it right now. So hopefully in the future, we will think of other ways in which we can provide this intervention.
And I guess being a proof of concept type of study, it's an early stage, and issues of diversity and inclusion are very important, obviously, but will hopefully be addressed at a slightly more advanced stage of evaluating this intervention. But I think at this point, if I understand Julie's aims correctly, it's really about establishing some of the basic parameters that we believe might be involved in giving rise to the expression of neuropsychiatric symptoms. So it's really quite an important exploration of the hypothesis that a combination of cognitive processes and metacognitive processes are at play together to give rise to these neuropsychiatric symptoms. And of course, Julieta, you may want to mention that we probably believe there are other factors that contribute to the expression of neuropsychiatric symptoms beyond impaired cognition and sort of changes in metacognitive processes, right? So there could be other factors, I imagine, maybe sort of pre-existing personality characteristics, of course, biological factors, and probably also cultural factors as well.
Absolutely. And also not all neuropsychiatric symptoms might have the same cause. And this is why I said at the beginning that it is a very broad term. And although we try to cluster them together, anxiety might not be the same as eating disturbances, for example. So they might have completely different causes, or could be related or could not be related. But this is why it's also really hard to try to target them all together. And that's also why I decided to focus on 4 neuropsychiatric symptoms to begin with the app. Yes.
I was going to say, do you want to add any more kind of thoughts about the specific 4 that you've decided to focus on, the neuropsychiatric symptoms that you've decided to focus on? Was that based on any kind of analysis of the evidence around frequency, or was it about the ones that are more salient or potentially more disabling when it comes to their functional impact?
Yes, it was a combination of all of those reasons that you just mentioned, and it was also a practical choice, I will say. As I said, I have experience in psychotic disorders, and that is why I know that it is not that easy, for example, to target psychotic disorders in this in the way that I am targeting these other symptoms. And so yes, together with the clinicians with whom I had the discussions, we decided that we were going to focus on these 4 symptoms at first. And yes, it has to do a lot with prevalence. We know that anxiety and depression are amongst the most prevalent neuropsychiatric symptoms in people with dementia, as well as disinhibition in particular types of dementia as well. And apathy is also a very serious problem that we see in people with younger onset dementia. So yes, it was a combination of all the things that you mentioned.
Great. Are there any other questions at this point for Julieta? I want to share with you all that Julieta worked incredibly hard over the last few months to put together this app from scratch, spending numerous hours in developing it, and I really want to congratulate you, Julieta, for doing an amazing job in developing what I think is a very, very novel and very needed resource, hopefully. So while the road is still long in terms of evaluating this now at the basic feasibility level, and obviously the kind of efficacy and effectiveness in a real world situation, I think this is an amazing project and an amazing achievement of yours, having done this without kind of background in app development, and you really have done an amazing job. So unless there are other questions or comments for Julieta, as she said, she's now finally recruiting for this study and has entered the last stretch of her PhD. So this is a really crucial few months for Julieta to recruit participants for her study, and she would be very, very grateful for any of you who might be in a position to spread the word and share the news about this intervention, which of course is open to participants from across Australia. Yeah, please do let Julieta know if you can assist in helping recruit participants for her study. And other than that, I'll just thank you again, Julieta, for giving us this talk today, and wish the rest of you a great rest of your day, and we'll see you in the next NARI session in a couple of days.
Alex, there is a question here, Ruth. Ruth, there is a link that I can share. I have actually shared information on my Twitter, which I will share with you. I don't know if you have Twitter or not.
I'll find you. I'll find you on Twitter.
Okay, thank you. All right. Okay, thank you, everyone.
Okay, thank you.
Bye-bye.